on to our next speakers. So this session is a pediatric care spotlight. Yeah, I've lost. Can anyone see a sheet with everyone's bios? Okay, it's at the back. All right. So Dr. Palmer is an assistant professor and faculty member at the Division of Immunology, the Department of Pediatrics. Thank you. At the IWK Health Centre and Dalhousie University in Halifax, Nova Scotia, where he looks after patients with suspected or confirmed inborn errors of immunity, including hereditary angioedema. He also carries out research and teaching activities. His main interests are antibody deficiency and immune dysregulation disorders, as well as characterization of B cell function. And Tess will be coming up to give a 10-minute talk afterwards. Tess is a subspecialty resident or fellow with the Department of Paediatric Allergy and Immunology at Dalhousie University, the IWK Health Centre, and the Halifax Allergy and Asthma Associates Clinic in Halifax, Nova Scotia. Her current focus is expanding access to care for pediatric patients with atopic disease and suspected or confirmed inborn errors of immunity. Tess is from St. John, New Brunswick, and is grateful for the opportunity to work with and learn from patients, faculty, and healthcare teams across Atlantic Canada. After fellowship, she looks forward to continuing to work in the Maritimes and collaborating further with the communities that trained her. Awesome. Quick round of applause for Alejandro.
Great. This is good. Okay. Well, so thank you for having me. It's the first time for me at Immunity Canada, even though I've worked with other organizations, as I said, back home where I'm from. But it's very rewarding actually to hear, for example, Ashley's story, because it always reminds us as of the why behind the whole process or the disease that, like feelings or experiences, and it's something I think it's the most valuable thing. But so since it's an educational day, I prepared something. Also, is this working? Oh, sorry. Oh, okay. I prepared a presentation to explain a little bit, because I find that sometimes we as physicians don't quite explain a lot, even though we try to use an easy language, or I found in my practice that whenever patients understand better the disease, the better at taking care of it as well. So I wanted to explain a little bit. Have a disclosure. I participated sometimes in advisory boards for these companies, but otherwise no disclosure. So I wanted to tell you a little bit about all these inborn errors of immunity that we've been talking about, to talk about a little bit about treatment beside IVIG or SCIG, because Gina has covered it very well, so I don't want to repeat that, and to talk about a little bit of newborn screening, because from the pediatric perspective, it has become very important, and it's something that has become, I believe, the standard of care. So just wanted to explain a little bit of that. So Gina said this, Gina explained a little bit of this, but I also wanted to highlight that it is, we do look into genetics now a lot. So we try to identify it and put a name on it. Actually, the name CVID to me is a term that I don't enjoy quite as much, because it is basically means there is a problem with your antibody production, yet I don't know what's the cause or the genetic cause. So we try to name it, and we try to characterize this a bit further. And so whenever we talk about genes, we're talking about a part of the genetic material. So to say that codes for a protein, and usually that protein is faulty. But that fault can be, as Gina said, a loss of function. So there's no protein, or there's a protein that's wrong in a way. And we call that a loss of function, but it can also be hyperfunctioning. And that's what causes what we call immune dysregulation sometimes, or it's associated to other kinds of diseases. So now the term inborn errors of immunity highlights that it could be a gain of function, a loss of function, or it could be dysfunctional rather than non-functional. So we always talk about cells, right? T cells, B cells. So I wanted to give you an overview as the textbook definition. I find that sometimes that patients don't read books. So it's the definition, it's a definition that's what we use as a hallmark, so to say, but then one has to be flexible and say, okay, this may not be exactly the definition, but I shouldn't rule it out. So the first one, and sorry, it doesn't read there very well, but the first one is the T cells. So the T cells are a kind of white blood cell that defends against, it's fundamental for defending against any kind of microorganism. So we can have viruses, we can have parasites, we can have bacteria, mycobacteria, or fungal infections, or thrush. I was actually shocked when a month ago or so, Tess and I received a referral for a patient who had chronic candidiasis or chronic thrush, which is a fungus in the mouth. And he got seen by us at 8 years old, and he had all this all his life. And even more shocking was that we got to see this boy because he was found incidentally to have a genetic diagnosis, not because of the clinical manifestation. And you know who referred first to the geneticist? The dentist. So I found that I was a little bit, I don't know, scared is a word, but it's like, I'm just wondering how many more are out there. And so that's why I think education is key and awareness is key, because, you know, thankfully the boy is doing well, but who knows, right? So, but T cells are in charge of all this, and they're fundamental. And the defect on them is what a full defect on the T cells is what causes severe combined immune deficiency, which is, I would say, one of the biggest emergencies in immunology, because it can be fatal. And what about B cells? So B cells are the more widespread, so to say. They take the scenery a bit more, and they are in charge of producing antibodies. So usually, as will probably actually have experienced this, there's a lot of infections, respiratory infections, sinus infections, ear infections, diarrhea, but it's mainly in the bacteria. Bacteria are the most important features there, but that doesn't mean that they cannot get viral infections. But the main feature, textbook feature, would be that one. And then we have phagocytes as well, which are the main, they're the main cells to patrol, so to say, for organisms there. And their fungal infections take quite a bit of the scene there. There is a defect that is either quantitative or functional. So there's a problem either in what they do, or in the numbers, or it could be both. But essentially, bacteria and certain fungi can be are what cause the problems there. And the other thing that is very important is that these children do not manifest as severely as one would think. I remember when I met my first chronic granulomatous disease patient. So I'm a pediatrician, so I see children. And it was this cute little boy of 6 years old who came and gave me a hug. And his chest CT that day showed a complete lung infection on like that covered almost one lung, and he looked absolutely okay. So it's certainly be aware of these diseases as well, and how damaging they can be. It's an important piece. And finally, not to bore you, there's something that's the complement system. These are proteins that circulating around the bloodstream, and they protect mainly against what we call capsulated bacteria. So pneumococcus, meningococcus, Haemophilus, these are all germs that we could provide vaccines for. Sometimes they're incorporated in the routine vaccination. We would wish that all of them would get it, but they're available, but mainly they're affected by that, and not so much as it's a more specific kind of susceptibility. And that happens with other kinds of infections too. This figure might seem very complicated, and I'm not expecting you to understand all these pieces, but there could be an immune deficiency or an inborn error of immunity when there's a single weird microorganism. It could be that, you make your daily life, but if you come with across this germ in particular, then we will know. And these are, there's mainly susceptibility to germs such as we call mycobacteria. And these are, in the soil, they're very common. So these are very tricky diseases, but one would think, okay, it was just one infection. Well, maybe not. I would look at it with the other eyes and say, okay, let's just investigate at least. And finally, last but not least, some of the immune dysregulation can happen with autoimmune manifestations. So what autoimmunity means, actually, just simply explained, is that the body is not recognizing itself and attacking itself, whether through antibodies or other mechanism. It's a loss of what we call tolerance, which means that we are recognizing what is our own, and that's broken. And it can be counterintuitive, but some patients who have an antibody disorder, you would say, well, they have low antibodies. How can this be possible? Well, the few antibodies that are being produced are a bit crazy. So they essentially are doing the wrong function as well. And we're also increasingly starting to see what we call periodic fevers, which is basically seeing children who have fever in a pattern that repeats itself. And some of these children, interestingly, have been thought to be just sick children, or, oh, I was very sick when I was a child. I was just the way I was. And in the end, there is a reason, and there are genetic alterations that can cause the immune system to activate without a trigger. And finally, we have something that is called HLH, which is a massive episode of inflammation. You don't need to know the specifics, but it is one of the manifestations as well. So on the whole, there's 10 kinds of immune deficiencies or inborn errors of immunity. And I just wanted to highlight how this has been growing in the last couple years. So this is an old slide. This is from 2022, so this is already outdated. But from the 80s to 2022, there has been a tremendous amount of discovery, and this is ongoing. And that's why I think the importance of research that David was mentioning is very, very important. Now we're over 500, I think. And this goes on and on. So, and I know there's been a couple of discoveries this year, so stay tuned for the new number. But I think, and also we're talking about rare diseases, that's true on their own, but together they're much more common than one might think. So it's always keeping the eyes open. And one thing I wanted to say also is, we were talking about these this kinds of group. There are sometimes problems that could be where the immune deficiency problem is one branch of the whole problem. And there are other manifestations. There could be hematology manifestations, there could be dermatology manifestations, and the immunology is one piece, a very important one, but not just the only one. So essentially, this has been very important for us to work with other specialties and say, okay, please refer these patients to me. And so some of my colleagues actually, or my friends who do other specialties would say, do you think this is weird? Like, do you think this would warrant you to see? And I'm like, absolutely, because at least I should take an eye on it. And so we've been collaborating a lot with genetics in our hospital. So we aim for a genetic diagnosis. I believe now it's in pediatrics, it has become the standard of care for immune deficiencies or inborn errors of immunity. And we have worked with Dr. Derfalbi to actually create these panels to be done at the IWK. Normally, we send genetic testing to a company that does it. In the past, as I said, in my previous center where I worked, we worked closely with the geneticists and we would actually discuss the results that were found, not getting a report. It's just seeing, okay, this is very relevant to you. We just get the process, like the whole result. And I think this will greatly increase our diagnostic rate and how we go around things. And we're actually going to start to discuss these on rounds, like official rounds. So I think that's very important for care. And also, it's not working. Oh, there. So here are some statistics of what we do. Not sure if this is working. Oh, okay. Well, I don't know. There's a problem with the slide, but essentially, I wanted to show how many visits we have a year or so. We see around 300, 400 visits a year. We cover all the Maritimes, so we do see patients from PI, New Brunswick, and we're also starting to get referrals from Newfoundland because we're not sure exactly how that's being covered. But we do have a link with what's called Jeffrey Modell Foundation. And we have to report sometimes. We have to report yearly or for a period of time our diagnoses. And the IWK is a Jeffrey Modell Center. So, and I actually wanted to explain what that is because I think it's very motivational. So I'm not sure if you know Fred and Vicky Modell. Who are those two people? So Fred and Vicky had a child named Jeffrey, and he had an inborn error of immunity. And he died, unfortunately, at 15 years of age in 1986. And that was, well, they were, after this, they were heartbroken, of course, and they did create the Jeffrey Modell Foundation, which is a foundation that has helped worldwide to understand inborn errors of immunity, to facilitate education, access. They've done a tremendous advocacy, and they've been a model for the world, really. And their story is quite moving. Actually, let's see if it works. I did include. They did a documentary in 2021. Actually, Vicky just passed away a few months ago, sadly, but she was a great inspiration. But basically, let's see if it works. But oh no, it doesn't work.
Well, I'll try and get it.
Anyway, this documentary is in YouTube. It's free. It's about 1 hour and 15 minutes. I think it's really inspirational story. But basically, what Jeffrey was saying to the parents is that no one knew about the disease that he had, that he wished that there were others, kind of, where people would understand what was going on. And he did ask the family, the parents, like, can you do something? And well, the documentary is actually called Do Something. And I think it's really, as a very strong story, they're very, it's a real story. And I think it could be any patient's story, to be honest. But these two parents have the strength to, you know, organize this that has become a worldwide phenomenon. And I think it's, yeah, really moving, and they're lovely people. I've met them. And so going to that, and again, going again to what Gina was saying, registry is important. Why? Because we need to understand better, but also for advocacy. Because usually when one goes to policy or to medication or things that the patients need, we need numbers. They do get, I agree with Gina, that's when patients do manifest, it's they hear better perhaps than a letter that we send. But I also think that proving it with raw evidence that is there is also, it's something that is like, you can't fight that. So and for that to happen, we need to have the numbers, and that's why the registry is very important. And I'm sure many, if not all of you know Beata De Fabi. She's our division head, and she's been a tremendous driver for this to happen across Canada. So this is, I think, we should see the people who are working behind this, because it is a tremendous effort. And they, this is happening all across Canada, and I think it's very important. And certainly, I won't repeat what Gina said, but basically what I wanted to say is that this will be starting in July. So I'm for sure going to tell my patients to let them know that this is available. But I think it's really important for us to improve the quality of attention as well. So so really, I mean, a lot of times the people ask me, what can we do? Like, we have this disease, what can we do? And we do talk about IVIG, we talk about certain specific treatments, but sometimes I feel it's useful to have a little bit of some general things. For example, when we talk about SCID, and I'll talk briefly about that because I'm running out of time, because I talk a lot, it seems. So the main thing is basically SCID is the bubble baby. So essentially we have to care a lot about hand washing, being very careful about isolating this child, very careful about food, and a lot of medical measures such as IVIG and prophylaxis. But again, for example, if we go to primary antibody deficiencies, one frequent question I get is there any food that I should avoid, or is there? Normally not really. I mean, of course, one should be mindful of eating healthy or normal measures, but it's not as limiting as something as SCID. And well, we use IVIG or antibiotic prophylaxis. Well, we talked about the complement deficiencies and HAE, so I won't stop in there. And there's a more specific things about diseases such as chronic granulomatous disease. We basically have to avoid any mold exposure or any fungal exposure, because they're really hard to eradicate. And finally, I wanted to talk a little bit about treatment that we do aside IVIG. So we seek that on one of the things that we look for genetic diagnoses is also to see, is this a disease that I can cure or not? And so what we usually do and try to determine is, and through this cartoon, what I try to show is there a problem at the bone marrow, and can I replace it or not? Or is the problem at the thymus, which is the creator of T cells, so to say? And so we attempt to either do bone marrow transplant in diseases that could be cured for that. And in some centers, unfortunately not everywhere, a thymus transplant is a possibility. I would explain more, but I don't have time.
Just that you could do a short presentation, so you've got a few extra minutes.
Okay. So, and the thing that I wanted to explain here is, lastly, I won't take a lot. I don't want to bore you. Is newborn screening. So, I talked about SCID. SCID is the most like the most urgent thing at a very early age. Children with SCID don't survive past the first year of life if not treated, and so it is fundamental. We do have newborn screening. And what does newborn screening do? We basically measure whenever T cells are created, they leave behind a small circle of DNA because they try to rearrange the receptor with which they recognize other, well, when they recognize substances that we call antigens. And they leave that behind. And normally there's quite a bunch of those. So every baby that is born in the Maritimes, I have to say, because this has not been widely available in all provinces in Canada, so we're thankful to have that. We get notified as soon as possible if there is one that has what we call low TREC. So TREC means T cell receptor excision circle, and it could be a false positive or not, that we follow up then and we just check their function. Is this easy? Not really. It brings a tremendous amount of stress to parents whenever they're notified of this because, well, they're worried about a deadly disease. And we try to make that an easier process, but at the same time, I have to say, as I come from Argentina as well, we don't have newborn screening there. And we also have a vaccine that's called BCG that is given at birth without any screening. And BCG can cause a severe disease in a child that has SCID. So I think, and we always get late there. Like we always, I've seen children die of SCID. It's not, it's heartbreaking, knowing that there is a cure and that can work 100% well. So I think, balancing, I think a little bit of over worrying in the beginning and not to miss a SCID is fundamental. And sometimes there are other centers that test for the B cell version of this as well. So it depends on the world, on the country you're in. But that's one of the tools that we're using now. And so I just wanted to thank you for having me. This is our team. So sometimes we, we're an email or a doctor calling, because if we're on call, we get like, we're not the primary physician. So these are my colleagues, and it's a great team to work with, and I'm thankful for that. And I'd be happy to take any questions, and hopefully I can answer them. So yeah.
Yes, do you want to do yours?
Oh yeah. Oh yeah.
Okay.
Yeah, of course.
Okay.
Yes.
I was curious about your thing there where you said you noticed a periodic fever in children. Can you explain the pattern?
Yeah. Yeah.
Just repeat the question as well, so they can hear.
Yeah. So how we talked about periodic fevers and what would be the pattern. So essentially, there are certain diseases that have characterized genes, and basically there would have repeated attacks over months or years, even depending on when we get the referral. And they can be, depending on the disease, they can have different patterns. So for example, it could be attacks of fever that last 1 to 3 days and usually there's a number of systems that are affected, such as usually there's abdominal pain, usually there are canker sores, and they can vary between each other. I have to say, regrettably, not all the time, more not than we don't find a diagnosis. And there is just, parents would come and say, there would be a period of every month. I know it's going to happen. Pardon? Oh, really? Yeah. So usually we see them over time. Usually there's no infections that trigger this. So we're always trying to exclude the infection piece, which is hard. But we also look for certain markers that show inflammation, and we try to target that. Does that make sense?
Yep.
Okay.
I could just say that like a couple weeks ago, we had parents, they started writing it. That's 3 days. And they started writing it down, so it like.
Yeah.
We've got no questions coming in online. Anyone else have any questions? I just had a quick one.
Yeah.
Do you have any guidelines out here for like transitioning from pediatrics to adult?
No, that's a good question. Well, we have a booklet kind of, but I think suddenly it's, I know in BC, Dr. Biggs and I think Dr. Biggs is the one who's actually doing a transition clinic, so to say. But yeah, it's something that I think we could work better on, at least on from the pediatric end. I try to hold them as much as I can, because yeah, for sure it would be something that I would be interested in improving, because it is a hard time for them to change to, you know, I feel that the pediatric center is like, we're over them all the time, and after they have to take care of themselves, it's a big shock. So I'd be interested in improving it however I can, if it is even with some some resource of even not talking about psychotherapy, but someone who could join them in their process. If that makes sense. Yeah, sorry.
I'm from Newfoundland, so I was curious when you said that you were getting referrals from Newfoundland. We actually have a really good complement of immunologists where we are. So I was just wondering, are you getting patients who need a stem cell transplant, or is it more?
So when it's interesting that you asked that. So I'm not very clear on what's happening there. In terms of, my understanding is that whoever was doing are you from an adult standpoint or children?
Well, adults, but I'm also a family physician, so.
Right.
I'm kind of involved.
So my understanding is that
I know that there was issues with the care, like they were taking it out of the hospital.
yeah.
Like,
So
yeah, my daughter was sitting at the hospital there.
so my understanding is that the people who do allergy and immunology in children are more devoted to allergy. I got this referral in particular because it was a case of HLH, which is the cost of the referral was to see what the problem immunologically was, but because the transplant need, we wouldn't take care of it because we're not a transplant center. We refer to Montreal or Toronto, unfortunately. But yeah, so I don't think that's the direct cause of that. But we're trying with SYNC, which is the clinical immunology network in Canada, trying to sort this out, because we don't want those patients to get lost, or we want to care for them. And I have actually quite a few families from Newfoundland. They're in Nova Scotia, but they stem from there, so the patients are there. And yeah, it's something that we're concerned about. But I can't, I don't know for sure. This is more hearsay kind of. So I received the referrals and I accept them. I don't reject them, no. Yeah, no, I'm happy to help wherever. Yeah.
So we just got a call from school that Monday to the January, it had that was the end of the team, and they are trying to find but now we are working out basically an outreach program. So we are going to be like the phone therapy consults, and you can see meetings with the colleagues there, and also probably be proposed a couple of times as well, up until the
Awesome. All right, thank you so much.
We're going to shift gears for a few minutes. I don't have any slides. We're just going to talk through things as we go. Read the picture on the screen. Thanks. My name is Tess. Thank you for the intro, and I'm one of the first-year fellows in the pediatric training program here for allergy and immunology at Dalhousie. And when talking about our meeting today, we thought it might be helpful at least to talk and share a little bit about what the fellowship training program looks like. I don't know if anyone in the room, patients or otherwise, I know some staff in the room I've worked with closely, but have you guys ever met a fellow along the way? Met some friend of face crowd? Oh yes, thank you.
Oh, sorry.
Like taller. Would like to be taller. Let's see. There. Hopefully that's okay. Yeah, so I think at Dalhousie, I am one of two right now fellows in the program, both in first year. The other is someone who I went through training with before starting fellowship. And a bit about me, so I'm a pediatric trained fellow. So I did my undergrad at Dalhousie, and then did my residency in pediatrics here at the IWK as well, and transitioned into fellowships. It's a 3-year residency training program for pediatrics. I just wrote my Royal College exam for pediatrics this week, hence partly no slides, but waiting for exams back. Thank you. Fingers crossed. And then it's a 2-year training program for both allergy and immunology. Program. We've been a training program for about 11 years, I believe. My program director currently, I think, was one of the first fellows to go through the program. And so it's changed a bit, I think, over the years. My day-to-day looks different depending on what rotation I'm on. So as a resident, every month we switch rotations, and those rotations are designed to try and help us meet our Royal College objectives in immunology and allergy. So we focus on primarily atopic disease, allergies, asthma, immunoregulatory disorders like Dr. Palma talked about, and immunodeficiency disorders like we're all quite familiar with, I think, in this room. And throughout the week, on an average week for me, I might be in clinic. We do academic half days, which is an educational half day across Canada where we talk about current evidence in immunology, in allergy, and learn from different staff that join and provide us insight from their own clinical experience along the way, and then some research along the way as well. We all have a project through residency and fellowship. What else? I guess for after my 2-year fellowship program, there will be another exam. So I just finished my pediatrics, and then we all will write another Royal College exam at the end, and that is an all-encompassing exam for both pediatrics and adult. Your clinical experience as patients, you may have seen someone who primarily practices pediatric immunology, like Dr. Palma would see only kids, Dr. LaCuesta would see primarily adults, and then in the community spread out, some staff will see a mix of both peds and adults and allergy immunology. And after training, a number of people will go off to do some extra training, whether it's a master's in basic immunology, medical education, depending on where they want to work. And so for me, after next summer, I will have to find, call it a real job outside of training. And whether that be in a primary academic center like Halifax or in the community, my focus day to day could be primarily allergy or immunology. So we do 50%. I think most of the immunologists end up doing a bit extra training in immunology, especially if you're working in an academic center, but it varies significantly. I think those are the big things we wanted to touch on. I don't know if anybody had any questions about residency fellowship, but thanks for hearing my spiel.
Thank you very much.